that means it's 9:01. Do you have any changes? Good morning. All right, if everyone could take their seats, please. We're getting ready to begin the meeting. Okay. Good morning. Welcome to CMS's annual HCPCS public meeting for drugs, biologicals, and radiopharmaceuticals. My name is Felicia Eggleston. I'm on the Part B drug payment staff, and I'm going to be your moderator for today. We would like to start by telling you that this meeting is being webcast via CMS. The CMS webcast is live, so it will begin as our meeting begins, which is now. By your attendance, you are giving consent to the use and distribution of your name, likeness, and voice during this meeting. You are also giving consent to the use and distribution of any personally identifiable information that you or others may disclose during today's meeting. Please do not disclose any personal health information. This webcast can be found in archives after the meeting on YouTube or the CMS Ustream website, and I believe that it is there permanently. Just to go over some housekeeping items, if you need to go to the restroom, you'll go out these double doors here, make a right down the hall, and you'll see the restrooms on your left-hand side. There are also phones right beside the restrooms, and if you continue out and make that left towards the lobby and then make the right by the elevators and continue down to the stairwell, you'll see our coffee stand and our cafeteria. We have been asked to remind you that, for security reasons, visitors may not enter any areas other than the public areas on the lower and first floor levels in the central building, unless you are escorted by agency staff. If any of you will be in assistance for arranging taxi service today, please see the concierge in the lobby. CMS is a non-smoking campus. There is a smoking area outside the building near both of the guard stations where the entrances are. We like to ask at this time that you put all cell phones and Blackberries on silent. We'd also like to ask that all speakers and anyone answering questions, whether you be an inside person or outside to the agency, that you would please come to the microphone so that we may all hear you. We'd also like to ask for everyone's cooperation in adhering to speaking time frames. Primary speakers have up to 15 minutes, and 5-minute speakers have up to 5 minutes. I will be keeping your time today via the time device up here to my right, to your left. It's going to show you, when you start, it's going to give you your allotted time amount, and then you can kind of keep track of it. For 15-minute speakers, once you get down to 2 minutes, I'll gently say 2 minutes, or you can kind of glance at it yourself, and we ask at the 2-minute mark that you wrap up. Should anyone use all of their time, I'll just stand up behind you, and that'll let you know that your time is up. Speakers may not call on any other speakers. Only I, the moderator, can call speakers. We will call a coffee break, time permitting, on today. And, we'll just kind of gauge how things go. I don't think that we'll be here long enough for lunch, but we will bear in mind coffee break. So, at this time, I'd like to introduce Cindy Hake. She is the Deputy Director of CM's Division of DemiPost Policy and of the CMS's National Level 2 HCPCS program. She will provide opening remarks and a brief description of the background and purpose of today's meeting. Cindy?
Thank you, Felicia. Good morning, everybody. So welcome to CMS's HCPCS public meeting for drugs and biologics again today. We'll have a continuation of this meeting tomorrow that will be for products that we call skin substitutes. We typically have with us at these meetings members of CMS's HCPCS work group, representatives of manufacturers and suppliers of some of the items on the day's agenda, government relations and regulatory and compliance specialist personnel, industry consultants, sometimes clinical specialists. Every once in a while, a few members of the press. I don't believe we have any with us today. We're very glad that you're here, and we look forward to your participation and hearing your unique perspectives as the day moves on. We know that you're very busy, and we also know that travel has become very expensive, so we really appreciate you taking the time and going to the expense to come here and share your comments with us today. This public meeting forum arose out of the Benefits Improvement and Performance Act of 2000, and we had our first public meeting back in 2002, and at that time the requirement is for durable medical equipment only. But we were pretty happy with the dynamic of the meeting and the fact that we were taking public input, and that it sometimes, as a matter of fact, caused us to change our preliminary decisions. So before very long, we expanded this forum to have public hearings and release preliminary decisions for every type of application before us, regardless of the category. Before HCPCS public meetings, CMS's HCPCS workgroup members convene and review each and every application before us, and we formulate the preliminary decisions that you see in your agendas and that you saw posted on our website. And we publish preliminary coding decisions, and for Medicare, we publish preliminary Medicare payment recommendations. The workgroup includes members who offer input based on their perspective of the national program operating needs of their particular insurance sector. So we have representatives of Medicare, Medicaid, the private insurance sector, Veterans Administration, and the Department of Defense, as we consider all the applications. We publish our preliminary decisions along with our rationale in advance of the meeting, as you know, and then via this process, we invite comments from applicants and anyone else to support or refute our preliminary decisions. And so as such, this public meeting process provides a reconsideration opportunity within the original coding cycle. After the public meetings, the workgroup reconvenes to consider all input provided up to and on the day of the public meeting as we begin to formulate final decisions. So this is not a decision-making meeting. This is your day today, your forum to provide us input on the preliminary decision that we've already published. And sometimes our preliminary decisions do change based on the input that we receive at these meetings, which confirms the value and importance of these meetings to us and hopefully to you also. Following this meeting, we'll publish a summary of the public meeting proceedings, and that will just be basically the summary that you have before you, and we'll add on that the main points that any primary speaker had to offer us at the public meeting. So that's an informational document. It would not include at that time any final decisions. Final decision letters and final decisions are captured in the HCPCS annual update, which is generally published the first week of November of every year. Most changes to the code set become effective January 1st of the following year. We've made some fairly recent changes to our process that have added transparency to this government process, and we've received some positive comments about them so far. One is that we began live streaming these meetings, so you'll be able to catch this. We are being recorded, the cameras are rolling, and you'll be able to catch this on YouTube after the meeting. Just go to cms.hhs.gov, and you should be able to find the link associated with the public meeting date. We also established a new web-based notice and comment process to gather input regarding internal decisions, CMS internal decisions to discontinue codes when that code is not replaced by another code. That is different because up until now, all our public input process has revolved around external HCPCS code applications that you guys send to us, but we're now seeking input on certain internal decisions also. If we have any internal decisions to discontinue codes that would not be replaced, that information should be published on our HCPCS website by July 1st of every year. And then we have a comment period and assimilate comments, and our final decision would be reflected in the annual update. We also began publishing our final coding decisions together with our rationale in two different formats, one in a spreadsheet format and one in a narrative format. This usually happens after the annual update is published, and we've got some time to go back and do this and fluff up these documents and make them nice. So you can, in one document, beginning to end, see everything we've considered for the year, what we've decided, and why. So that is all I have for you today. We look forward to your participation, and again, thank you for joining us today.
Okay, I'm back. At this time, I'm going to read the Medicare Part B payment piece. Medicare Part B pays for a limited number of prescription drugs. For the purpose of this discussion, the term drugs will be used to refer to both drugs and biologicals. Currently, covered Medicare Part B drugs generally fall into three categories: drugs furnished incident to a physician's office, drugs administered via a covered item of durable medical equipment, and drugs covered by specific statutory provisions like immunosuppressive drugs, blood clotting factors, certain oral anti-cancer drugs, oral anti-emetic drugs, pneumococcal, influenza, and Hep B vaccines. Medicare pays for some Part B drugs using the cost or prospective payment methodology. Typically, under a prospective payment system, such as the outpatient prospective payment system, drugs are not paid for separately. Instead, payments for these drugs that are furnished during an encounter are bundled or packaged with other services furnished during the encounter. However, most Part B drugs are not paid on a cost or prospective payment basis and are paid for separately. Historically, there have been three approaches that have been used to determine payment amounts for this latter group of Part B drugs. Prior to January 1, 2004, payment for the majority of Medicare Part B drugs was set at 95% of the average wholesale price. Effective 2004, the Medicare Prescription Drug Improvement and Modernization Act of 2003 reduced the payment rate for most covered Part B drugs from 95% of the AWP to 85% of AWP. Effective 2005, the MMA required the implementation of a new pricing system based on a drug's average sales price, what we refer to as ASP. This approach is currently used to pay for the majority of Part B covered drugs. In accordance with Section 1847A of the Social Security Act, manufacturers submit sales data for their products to CMS each quarter. This data includes the manufacturer's average sales price for each drug and the number of units of the drug sold to purchasers in the United States in a calendar quarter. The average sales price that manufacturers must report is net of discounts, such as volume discounts, prompt pay discounts, cash discounts, free goods that are contingent on any purchase requirement, chargebacks, and rebates. The statute requires CMS to calculate a payment amount by determining the weighted average sales price for the drug products assigned to a specific HCPCS billing code and adding 6% to the weighted average amount. If an ASP is not available, for example, if a drug is new to the market, the wholesale acquisition cost may be used instead of the ASP. Very few sales are exempt from ASP reporting. There are exceptions to the ASP pricing methodology. These include those drugs that are paid based on methodologies such as the AWP. These include your influenza, pneumococcal, and Hep B vaccines. It also includes infusion drugs administered through DME, blood and blood products, excluding blood clotting factors, and radiopharmaceuticals. So, payment for Part B drugs is determined at HCPCS billing codes level. In order to facilitate appropriate payment, it may be necessary to create unique HCPCS Level 2 HCPCS codes for certain products. CMS has continued to review how the statutory terms single-source drug, multiple-source drug, and biological product, because they are used in the context of payment under Section 1847A to identify the potential need to make any changes to our assignment of national drug codes to billing codes for payment purposes. Also, in accordance with revisions to Section 1847A of the Social Security Act made by the Affordable Health Care Act, CMS has begun to incorporate biosimilars that are approved under the abbreviated biological approval pathway into the ASP payment methodology. So that we can implement coding and pricing changes promptly, CMS has used and will continue to use its internal process when appropriate for modifying and updating the HCPCS code set. Please be aware that internally generated code requests are not part of the HCPCS public meeting process. If you need any more information, our contact information is SEC, S-E-C, short for Secretary, 303 ASP data at cms.hhs.gov. Again, that mailbox is SEC 303 ASP data at cms.hhs.gov. And there is a copy of the payment piece in your agenda for today at the end. So, at this time, I'd like to introduce other CMS HCPCS staff. Many of you have had the opportunity to speak with them during the course of the cycle, to have your questions answered and all. Now we're going to introduce them so that you can have a name with a face. So I'd like to ask that as I introduce you, that you would stand, please. Judy Wallace, Nathan Hellman, Kimberly Combs Miller. Okay, she stepped out for a moment. I do apologize. These are your 3 National HCPCS Workgroup Meeting coordinators. We also have Archana Verma, who is an intern to the HCPCS staff. So, our workgroup meeting coordinators, they work very, very hard to put together all the thousands of details that are necessary in order to provide you this opportunity for public comment. We'd also like to introduce to you Dr. Crystal Simpson. Dr. Simpson is a medical advisor to CMS's HCPCS workgroup. We'd also like to thank the man behind the booth, Mr. Charles Hirsch, as well as his team. He has a couple of other people back there with him. And we'd like to thank him for handling all of our audiovisual needs. Now, we'll describe how the meeting will proceed. So everyone should have received the meeting agenda before they came into the room. If you have not, there are still copies available out on the table. For each item on today's agenda, there's a written summary of the application as well as CMS's preliminary coding decision. The meeting will proceed one item at a time until we have completed the agenda. We will hear a presentation from the registered primary speaker and any 5-minute speakers, if there is any. We would like to ask that every speaker state who you represent, state your relationship to the applicant and to the manufacturer, declare in your oral presentation and in your written summary whether or not you have any financial involvement with the manufacturer or competitor of any item or services that are being discussed today. This includes any payment, salary, or benefit provided to you on behalf of the manufacturer. We'd also like to state whether you agree or disagree with the preliminary decision, and when summarizing your comments, state your rationale for agreement or disagreement. After we've heard from all registered speakers, we will invite discussion and questions specifically related to that item. So, at this point, I'd like to introduce the first agenda item. Agenda item number 1, attachment 16.28, request to establish a new level 2 HCPCS code to identify Kanuma. Primary speaker is Ms. Carolyn Hickey.
Good morning, I'm Carolyn Hickey, Director of Global Pricing and Reimbursement with Alexion Pharmaceuticals. Financial disclosure, I'm an employee of Alexion Pharmaceuticals. About Sabelipase alpha. Sabelipase alpha is a recombinant human lysosomal acid lipase indicated for treatment of patients with a diagnosis of lysosomal acid lipase deficiency. When properly functioning, LAL processes cholesterol esters and triglycerides in the cells. Patients with LAL deficiency experience rapid lipid accumulation due to the reduction in activity of the LAL enzyme, or the LAL enzyme is actually deficient and not functioning. And this accumulates lipids in the tissues, and this particularly affects the liver, causing fibrosis, organ dysfunction, and failure. It also impacts other organs in the body, including the cardiovascular system, the spleen, and the GI tract. Sabelipase alpha is the first enzyme replacement therapy developed for patients with LAL deficiency and was developed to directly address the root cause of disease by replacing the missing or deficient enzyme. Sabelipase alpha is a novel FDA-approved therapy. Its brand name is called Kanuma, and it was approved by the U.S. Food and Drug Administration on December 8, 2015. Prior to the FDA approval of Sabelipase alpha, there were no safe and effective regulatory-approved therapies available to treat patients with LAL deficiency. Most therapies are only supportive in nature and do not address the underlying defect of LAL deficiency. Supportive treatments include lipid-lowering agents as well as liver transplant. Alexion requested a new Level 2 HCPCS code to identify Sabelipase alpha. Sabelipase alpha is a physician-administered therapy via intravenous infusion. The recommended dose for patients with rapidly progressive LAL deficiency presenting within the first 6 months of life is 1 mg per kg once weekly. For patients who do not achieve an optimal clinical response, the dose can be increased to 3 mg per kg once weekly. The recommended dose for children and adults is 1 mg per kg once every other week. When I submitted this presentation, there was no HCPCS code available, but just last week, CMS released pass-through status for Sabelipase alpha with a C code of 9478. Injection Sabelipase alpha, 1 milligram. A unique code is necessary for Medicare and other payers to appropriately identify and reimburse Sabelipase alpha. Alexion requested a new J code with the following descriptor to specifically describe Sabelipase alpha. Injection, Sabelipase alpha, 1 milligram. Alexion concurs with CMS's HCPCS recommendations for Sabelipase alpha. Alexion supports and thanks CMS for recognizing a new J code is necessary to describe the use of Sabelipase alpha. We recommend that CMS establish a J series code for injection Sabelipase alpha for 1 milligram, as proposed in the preliminary decision. Thank you. Okay. Are there any questions? No? Okay, thank you.
Thank you. Agenda item number 2, attachment 16.30, request to discontinue existing code J8565. Primary speaker, Mr. Blaine Squires.
Good morning, working group. My name is Blaine Squires. I'm the Executive Director for Access Services with AstraZeneca. I am a paid employee. I'm here today to contest the preliminary decision of removing the existing J code J8565 for gelfitnab, or commonly known as Orissa in the marketplace. The reason we want the J code to be removed is Orissa has no IV equivalent in the marketplace. It is not covered under Medicare Part B. J8565 has been regularly reviewed by CMS staff in order to update or confirm status indicators as evidenced in CR 9014, dated December 2014. It's an ongoing review of this J code continues to create unnecessary administrative burden for the agency when the J code serves no purpose. And again, maintaining a J code for an oral drug with no IV equivalent inappropriately differentiates Orissa from other oral cancer therapies. My final comment is in reference to a CMS transmittal around the Medicare demonstration codes dated publication 100-20, transmittal 1575, about CMS speaks to the removal of complexity in coding and archiving obsolete Medicare demonstration codes. As a background, the long-defunct demonstration program, the Medicare replacement drug demonstration, which predated the creation of Medicare Part D, was the origin of the Orissa J code. CMS maintained no other J codes for the oral drugs in that 2014 program. And again, speaking to the publication 100-20, the transmittal speaks for CMS's need to remove complexity in coding and archiving obsolete Medicare demonstration codes. I'll highlight the final bullet under that CMS transmittal, and it says, since some Medicare demonstration projects no longer serve a business need and claims processing for the demonstration is complete, contractors shall identify Medicare demonstration projects and codes that are not active. CMS believes archiving obsolete Medicare demonstration project codes will reduce system complexity and make future maintenance efforts more efficient. That is all I have. Any questions?
Thank you. If you haven't yet provided your written comments or summary to us, would you please do that?
I submitted those,
Good.
so
Okay. Thank you.
absolutely. Thank you.
Agenda item number 3, attachment 16.31, request to establish a new level 2 HCPCS code to identify NeuroSeq. There are no speakers for this item. Are there any questions or comments? Agenda item number 4, attachment 16.47, request to establish a new level 2 HCPCS code to identify Coagadex. There are no speakers for this item. Are there any questions or comments? Agenda item number 5, attachment 16.36, repeat request to establish a new level 2 HCPCS code to identify Omidria. Primary speaker, Dr. Michael Miller.
Good morning. I'm here on behalf of Omeros to talk about Omidria. I'm Dr. Mike Miller. I'm the Senior Health and Life Science Advisor at Foley HOAG. And forward. Very good. Omidria is an FDA-approved drug for maintaining pupil size and preventing pupil contraction and reducing postoperative ocular pain associated with cataract surgery and intraocular lens replacement. Contains two ingredients, phenylephrine, ketorolac, in a preservative-free, bisulfate-free solution and manufactured in a GMP-certified facility. It's proven effective, safe, and well-tolerated. It's easy to integrate into the operating procedures, routines for these kinds of surgeries because it's a single vial that's placed into the 500 milliliter of standard irrigation solution, so the drug is delivered throughout the surgery at a constant rate as the irrigation solution goes through the eye during the procedure. Omidria avoids the risks associated with compounded products that are used during the surgeries or could be, and reduces the risk of surgical complications, as I'll go into. It has clinical meaningful benefits seen in the registration trials I'll go through a little bit. And independent post-launch analysis have also shown evidence of the product's efficacy across a broad range of cataract surgery patients. Omeros is requesting a unique HCPCS J code from Omidria for the following reasons and disagrees with the preliminary decision. Omidria is a new product, and payment for cataract surgery actually does not include payment for Omidria because there is a pass-through status for the drug. There should be a unique J code for Omidria because many private insurers do not recognize the C code. And when claims are filed under the C code, it causes inefficiencies and confusion and delays in payment. A unique J code would reduce this confusion and between the drug and any other possible J codes or just not a code to reimburse for. CMS also recently requested input on the conduct of cataract surgery in physician office settings, where a C code would not be useful either for Medicare or private payers because they don't have that's not a code they reimburse for in the physician office setting. Let me talk a little about the medical challenges of cataract surgery and intraocular lens replacement surgery. Basically, during surgery, if the pupil contracts meiosis, the risk of complications increase by multiples, particularly when the pupil gets to be less than 6 millimeters. Preoperative topical regimens like eye drops do not stay in the eye because they just run out and the irrigation solution just washes them out. And also, anybody who's put eye drops in, you know, sometimes it ends up in the cheek instead of the eye. There are two serious complications that can occur from these kinds of surgery. Cystoid macular edema, which is from the problem of inflammation in the retina, non-infectious, and toxic anterior segment syndrome, which is in anterior part of the eye, also an inflammatory process, non-infectious. And then again, there's the risk when using compounded products that's been seen in other cases. Let me talk a little bit about sort of a graphic example of the post-operative ocular pain and the challenges of doing this kind of surgery. In the top panel here on the bottom, you can see a dilated pupil. That's really the visual field for the surgeon to operate through, is the dilated pupil. The bottom panel there of the series is a constricted pupil. And over on the very bottom far right, you can see, hopefully, there's the folded lens they're trying to replace the native lens with, and trying to insert that through the constricted pupil creates a lot of challenges. There are other things that can be done to expand the pupil in terms of mechanical devices to pull the iris open, but that can cause more damage and more inflammation and more post-operative pain. Omidria addresses an important need for all these potential complications. It dramatically increases the likelihood that the pupil will be greater than 6 millimeters. There's actually a typo down here in that first paragraph. Omidria increases the likelihood of the pupil being greater than 6 millimeters fourfold versus just phenylephrine alone. And here's what the typo is. It's actually nearly sixfold versus ketorolac alone and nearly eightfold versus placebo. I won't go into the math, but having a 2.5 millimeter decrease in pupil diameter represents a 50% loss in that size of the field to operate through because of the area of a circle is pi r squared times the diameter. And then in terms of pain relief, post-operative pain, Omidria decreases the occurrence of moderate to severe pain by 50%, and that moderate to severe pain is equivalent to what people experience after hip replacement. And it also reduces the incidence of pain-free post-operative experience by 50% as well. Post-approval studies confirm the benefits of Omidria. They've shown results about reducing the complications because of small pupils, decrease the use of the pupil expanding devices that I mentioned, which increase the trauma to the eye and add expense, reduces the constriction of the eyes when surgeons use the femtosecond laser-assisted surgery, which is another way to remove the native lens, and they reduce the surgical times and improve visual acuity the day after surgery. Private insurers often do not recognize the C codes. Millions of the cataract surgeries and intraoperative lens replacements are done in non-Medicare patients annually, and there's a list of some insurers that do not recognize the C codes, large national insurers and state Blue Cross Blue Shield plans. And providers must bill many private insurers for Omidria using the miscellaneous code, and that results in inefficiencies, errors in the data set, inappropriate denied claims, or delayed payments. Medicare beneficiaries may be denied access to Omidria because 90% of Medicare beneficiaries also have secondary insurance, and those secondary insurers may also not know how to use the C code in their processing systems. And that can lead to coverage for Omidria co-payments inappropriately denied or delayed. Medicare Advantage similarly may use coding rules similar to how they bill for their private insurance, and therefore they may not be able to use the C codes. And a unique J code for Omidria would make this difficult process much easier. Physician's office use and confusion with existing J codes. First, CMS recently requested input on the conduct of cataract surgery in the physician's office setting, but the C code is not recognized by Medicare or private insurance plans in Omidria's use in office settings. It's not on the slide here. There was recently, in April, a publication, study done at Kaiser Permanente in Colorado, where they looked at doing cataract surgery in the office visit, in the office setting, three of their offices in Colorado, 21,000 patients over 3 years. By the end of that 3 years, they were doing more than 95% of their cataract surgeries in the outpatient setting, in the physician's office setting. The average age of those patients, I believe, was about 72 years old. And again, the existing J codes describe the active ingredients, but not Omidria. It would be inappropriate to use these codes for phenylephrine and ketorolac to bill for Omidria. And in the absence of the J code, practices may mistakenly bill for Omidria by inappropriately utilizing these J codes for one or the other, and claims could be denied. The claims data set gets corrupted, if you will, and claims could be reimbursed inappropriately. To summarize, Omidria improves outcomes and reduces complications in cataract surgery and other intraocular lens replacement procedures, which are very common procedures among Medicare and non-Medicare beneficiaries. Omeris urges the HCPCS work group to reverse its preliminary coding decision and assign a unique HCPCS J code to Omidria. Because many private insurance plans do not recognize the C code, their claim systems aren't set up to use it. The existing C codes do not allow electronic crosswalk to the primary Medicare claims from the primary claims days, Medicare claims to secondary supplemental payers. A unique J code would reduce confusion with the existing J codes for the active ingredients and the existing C code will not be recognized by Medicare or private payers in physician office settings. Substantial efficiencies and savings and resources can be achieved if Omidria is assigned a unique J code, and in the absence of the unique J code, access to Omidria could be limited for commercial patients and Medicare beneficiaries. Thank you. Happy to take any questions. No questions? Thank you.
Agenda item number 6, attachment 16.43, request to establish a new level 2 HCPCS code to identify Portrazza. There are no speakers for this item. Are there any questions or comments? Agenda item number 7, attachment 16.56, request to revise existing code J7297. Primary speaker is Dr. Jessica Grossman.
Thank you. I work for a nonprofit pharmaceutical company called Medicines 360, and they pay my salary. Thank you for taking time to listen to our request. I'm here today to talk about Liletta. Liletta was approved in February of 2015 by the FDA based on data submitted through the Access IUS trial. This trial was the first and only FDA-approved phase 3 study for an IUD conducted exclusively in the US. Access IUS was performed and is still currently being performed at 29 sites, including public health clinics, private offices, and university centers. The study has enrolled over 1,700 women aged 16 to 45, including nearly 60% of women who have never had children or given birth before. Those are called nulliparous women. The largest group of such women ever included in an IUD approval study. And the demographics of the study mirrored the US Census. What is notable about Liletta is that it was brought to market with the goal of increasing patient access to contraception. However, in recent months, there have been access hurdles. In the 12 months since launch, Liletta has used 2 different J-codes. And with that transition came a series of issues for payers, providers, and ultimately the women in need of contraception. Medicines 360 and Allergan have a unique partnership. Access is the entire reason this product was brought to the market. In 2009, when Medicines 360 was started, a foundation passionate about women's health recognized a significant disparity in the number of unplanned pregnancies and access to highly effective contraception, especially among women of low income and women without insurance. To bridge this gap, Medicines 360 was formed, a global nonprofit pharmaceutical company with a mission to expand access to women regardless of their socioeconomic status or their insurance status. To help expand access to Liletta, Medicines 360 formed a partnership with Allergan, who does our commercialization and our distribution. Allergan has the largest women's healthcare division in the world, and this partnership is dedicated to increasing access to Liletta for all women. To ensure that our mission is successful, Liletta is offered at a $50 price to 340B eligible safety net clinics, those with a significant underserved population. This offering has already reached 33,000 women in the past year alone. These 340B sales represent 47% of all Liletta units sold. 18% of all Liletta claims submitted in January and February of 2016 were submitted to fee-for-service Medicaid. We are requesting a modification to our J-code that will describe both Liletta now and in the future so that we don't have to keep visiting you year after year. Liletta's current J-code descriptor, J7297, was requested by a different IUD manufacturer. It does not adequately describe the product based on the current label, and it presents problems for describing Liletta in the future. It will introduce unnecessary administrative burden that may decrease access to the women who need the product most. Therefore, Medicines 360 is proposing a change to the descriptor that will improve the descriptor to not reflect duration of use, and instead to consistently describe the product based on our clinical trial data to indicate it for both nulliparous and parous women. As I said before, the Access IUS trial is ongoing. We have 29 active clinical trial sites. There are 1,700 women in the study today. That the women will continue to support additional data for a 4-year indication for use for Liletta, then a 5-year indication for use for Liletta, and finally for a 7-year indication for use for Liletta. The study is anticipated to continue through December of 2019 and to provide data for Liletta's extended use through 2021. As you can see, submitted publications show that Liletta's value spans beyond the indicated 3 years of use indicated with the current J-code descriptor. We have a publication in Contraception that shows that our IUD can be used, IUD release rates for up to 5 years. We have a publication that was presented on amenorrhea rates for women up to 4 years. And just yesterday at the American College of Obstetrics and Gynecology, a publication was presented for return to spontaneous menses after removal Liletta for for women both 4 and 5 years after using Liletta. So the coding cycle with HCPCS will be asynchronous with Liletta's label, and that will cause ultimately barriers to access. Over the next 4 years, Liletta's label is anticipated to expand to 4 years, 5 years, and then finally to 7 years. Liletta's existing J-code descriptor would need to be altered and updated with all of these potential label changes. That means we would be visiting you again next year, the year after, and so on. These potential changes will cause barriers to access and confusion among payers and practices. With each FDA label update, extending Liletta's duration of use, the J-code will not reflect this change until at earliest January of the following year. There would be a substantial lag, leaving Liletta without an appropriate J-code for approximately 1.5 years following each extension approval. Additionally, for each of these updates, there is considerable efforts, cost, administrative burden, and disruption among both providers and payers. For example, the government, specifically state Medicaid, must update both their coding and fee schedule systems, which adds administrative burden and expense and causes provider disruption. Commercial payers manage Medicaid programs require the same changes, and none of these changes occur simultaneously. The same provider may be using different codes for different payers at the same time. There is significant effort required with HCPs to support and troubleshoot these changes as new communications and education materials need to be developed. The latest J-code change for Liletta in January of this year caused a great deal of administrative burden for providers and payers. 11% of the IUD claims submitted in January of 2016 were placed under the old J-code, J7302, and not the revised J7297 for Liletta, nor the appropriate J7298 for Mirena. In addition, 3.7 commercial patients and 3.7 million commercial patients and 12.4 million Medicaid patients were not covered under J7297, illustrating the time delay for all payers to update their systems. Similarly, when the Mirena device was updated in 2014, providers faced an administrative burden with older NDCUs. More than 6 months after the release of Mirena's new device, the majority of claims were still submitted under the old NDC, illustrating that updating information causes administrative issues unless there is considerable communication and investment in generating awareness and training. The ramifications for Liletta's J-code descriptor change could similarly cause disruption for over 6 months following each change. Making our requested change to Liletta's J-code and eliminating the 3-year duration of use will avoid a similar amount of disruption and administrative burden. As you can see, there are currently 3 hormonal IUDs on the market, but all of these IUDs have variations based on parity and age. There are a few key differences between the 3 IUDs, and it becomes important to highlight the differences that actually describe the devices and do not have the potential to change, like duration of use. Clarifying the J7297 J-code and focusing on the over 50% nulliparous women that were included in our clinical trial will help providers to use these devices appropriately in accordance with their FDA-approved labels. Market research shows that HCPs are actually confused by the indications of various IUDs. While recommended for women who have had more than one child, or Paris women, Mirena continues to be utilized for a large portion of nulliparous women. Women aged 16 to 25 account for 40% of all IUD claims submitted January through February 2016. And while the average first age of pregnancy is 26 years of age, it's safe to assume that this population is heavily nulliparous. Nevertheless, 25% of Mirena claims submitted in January through February of 2016 were for women in this age bracket. These statistics indicate that utilization and recommendations by HCPs that do not match the FDA-approved label for these products and providing clarification in the J-code descriptor will help them to make more appropriate treatment decisions for their patients. So this descriptor change will accurately describe Liletta both today and in the future, avoiding unnecessary administrative burden, inaccurate coding and reimbursement, which will decrease patient access. It also provides physicians with guidance to clearly understand the approved label for Liletta for use in both nulliparous and parous women. But most importantly, the modifications proposed here fall directly in line with the values that CMS itself has put forth. In her memo from April 8th of this year, Vicki Wacchino, the director for the Center for Medicaid and CHIP Services, states, beyond preventing unplanned pregnancies, research indicates that effective contraception helps prevent poor birth spacing, thereby reducing the risk of low birth weight or premature birth infants. It can also be essential to a woman's long-term physical and emotional well-being. LARCs, which include IUDs, are highly effective methods of birth control, but LARC utilization in the US remains relatively low when compared to rates in other countries. More can be done to increase the use of this form of contraception. One such strategy proposed by Ms. Wacchino in her memo to help improve access is, quote, removing administrative barriers for provision of LARCs, such as allowing for billing for office visits and LARCs on the same day, will help increase their utilization here in the US. We greatly appreciate your consideration and support for removing the administrative barriers and to providing women access to this affordable and highly efficacious form of contraception. Any questions? Oh, sorry. Was I not supposed to say that? Sorry.
At this time, we'll hear from Kevin O'Leary, a 5-minute speaker. Yes, right here.
Good morning. I'm Kevin O'Leary, Vice President of Strategic Pricing and Reimbursement at Bayer Healthcare Pharmaceuticals. I'm a full-time employee. Bayer manufactures Mirena, a 5-year intrauterine contraceptive device that has been available since 2001. Bayer's position today remains consistent with our comments at the 2015 HCPCS work group meeting to maintain separate and distinct HCPCS codes for IUD products to support billing and payment accuracy, for the appropriate treatment and management of patients, and for accurate processing of Medicaid rebates. Mirena and Liletta contain the same drug and the same dosage, but they are not interchangeable products, and they have different indications. Both are single-source products approved by the FDA under separate NDAs. We recognize that their similarities create a coding challenge to accurately distinguish these products for billing and payment purposes. Even if the duration of use were the same, as Allergan has stated may be the case in the future, maintaining separate codes would be appropriate. However, we believe that Allergan's request to revise the code descriptor for J7297 to include the statement nulliparous and parous would be inconsistent with its FDA indication and with clinical practice. Healthcare professionals prescribe IUDs for treatment based on clinical benefit per the FDA indication. Liletta is indicated for prevention of pregnancy for up to 3 years. It is not expressly indicated for nulliparous and parous women. Mirena is indicated for intrauterine contraception for up to 5 years and has a second indication for treatment of heavy menstrual bleeding. While Mirena is recommended for patients who have had at least one child, it is not contraindicated for patients who have not had children, and physicians commonly prescribe it for nulliparous women. Accordingly, we would not recommend using the words parous or nulliparous to distinguish these products, since they do not differ clinically as used in these populations. The ideal approach for Bayer would be to include the product's brand name in the descriptor, as is today the case with skin substitutes and visco supplement products, and used to be the case with Mirena. We respectfully request, if that is not the direction that the work group is going, that CMS reconsider the current descriptors and use the clinical indications instead of the years of duration as a more appropriate way to distinguish the J-codes and products for billing purposes. Specifically, we recommend revising the code descriptors for J7297 and J7298 to remove the years of duration of use and to include only for J7298 reference to the FDA-approved indication for treatment of heavy menstrual bleeding. This would distinguish these products because Liletta does not have an indication for HMB. By maintaining separate codes for Mirena and Liletta and adjusting the descriptors for J7297 and 7298, CMS will ensure that physicians and payers can accurately identify which IUD was used based on the FDA-approved indication as determined by dosage and clinical benefits as are laid out in the package inserts. If you make no changes in these codes and the letter receives a 5-year indication at some point in the future, we will again be in the confusing situation of 2 different products fitting under one code descriptor. We have included suggested wording in the statement I will submit. Thank you for this opportunity and for your vigilance in maintaining a system that makes sense for everyone. Thank you.
We will now hear from Catherine Wheeler-Frink.
Good morning. My name is Catherine Wheeler-Frank, and I'm the Regional Director of Health Services for FemHealth USA, a national family planning organization under which our CareFem Health Centers provide long-acting reversible contraception, including the intrauterine contraceptive device Liletta. We provide IUCs to women so that they may control the number and spacing of children they have throughout their reproductive lifetime. One of the many hats that I wear at FemHealth includes working insurance claims for services rendered to be reimbursed by third-party payers. I have seen many women desperate for the most effective method of contraception, only to be denied access because her insurance benefits did not fall in line with her provider's recommendations. As a representative of both patients and healthcare providers, I'm speaking to you today as not only to voice my support of LARC, but also to urge you to thoughtfully consider this request to modify the descriptor of Liletta. As a speaker on behalf of Medicine 360s, I am being reimbursed for my time and travel to attend this meeting in support of this code change. Currently, the code J7297 describes this device as levonorgestrel releasing IUC 52 milligrams, 3-year duration. However, as previously discussed, Medicine 360's intentions to submit data to the FDA to prompt a label change increasing the device's duration from 3 to 4 years is on the horizon. This change will create an FDA label of a device that is inconsistent with the HCPCS code, effectively creating a medical device that is not billable for reimbursement. Without a proper descriptive code available to healthcare facilities, women who desire access to this device and its easy to use, get it and forget it contraception would hit a barrier. Even though Liletta is one of the most economical LARC devices on the market, it's still a costly, upfront, out-of-pocket expense for many women. If healthcare providers cannot seek reimbursement for this device because of a descriptor FDA label discrepancy, it is women who will ultimately feel the burden. A little over 4 weeks ago, CMS released a memo urging providers to increase access to LARC while reducing administrative barriers. This is a perfect example of an administrative barrier decreasing access to the options of a woman who, with her provider, is convinced that this IUC is the most effective method that best fits her lifestyle. Secondarily, the current HCPCS description only refers to the dosage and duration of the device. Many young women entering the workforce and perhaps are newly married who may be financially unprepared to start a family are seeking a long-acting contraceptive method. In my experience working with family planning and OBGYN providers, patient selection is often based on the women's history of childbirth. However, evidence-based best practices have shown that nulliparous women with no other contraindications are excellent candidates for long-acting contraceptive IUCs. The bias some providers have against IUC insertion in nulliparous women is based in part on archaic and often incomplete clinical experience. The impact of changing the J-code descriptor now is threefold. If the descriptor were changed from its current version to levonorgestrel releasing intrauterine system, 52 milligrams for nulliparous and parous women, the coding and reimbursement for the device would not be interrupted. Women and providers would not face an administrative barrier that impedes access to this method of LARC, and all women, whether having delivered a child or not, would be a viable candidate for this method of her choice. Thank you.
Are there any questions or comments?
Dr. Grossman, you mentioned in one of your slides that certain parameters would not change when you went from 3 years to 5 years to 7 years. What parameters were those?
Thank you for your question. Shall I repeat the question?
I think everybody might have.
Okay. The parameters that will not change over the extended duration of use and the active time of our clinical trial, which will run till 2019, are the inclusion criteria of the women, right? Because the women in the trial are in the trial now. Their characteristics are not going to change. And as we said, almost 60% of those women that enrolled in the trial were nulliparous. So they had never had children before. And so the woman who started in the trial will complete the trial out to 7 years. She will remain nulliparous throughout.
Do you anticipate the FDA-approved indication changing to include whether they're nulliparous or multiparous?
We do not anticipate the FDA approval to change except for the indication for use today. So except for 3 years, 4 years, 5 years, and 7 years.
Thank you.
Any other questions?
When you did slide 3, you said the current code descriptor does not reflect the current label. What about the current code descriptor does not reflect the current label?
I was specifically describing how the current label talks about having both parous and nulliparous women included in the study, as well as women aged 16 to 45, as well as women with high BMIs. Those are all included in the label.
There's no restriction as to which women in the current code descriptor. So
You are correct. There's no restriction, but there's also no restriction on heavy menstrual bleeding. So just as our colleague from Bayer was talking about, we're not restricted to women who have heavy menstrual bleeding.
we don't usually put indications in the code descriptors, so that's... I just wondered why the current code descriptor didn't reflect the current label. So thank you.
Anything else?
Thank you. I'd like a bit more clarification on the access issue. You're asserting that the 3-year descriptor in the coding label or in the code is creating an access issue. So can you talk more about that and clarify how the 3-year stipulation is leading to a barrier to accessing the device?
The current label, I'm sorry if I was not clear. The current label at 3 years isn't preventing a barrier, but what will prevent a barrier is we are submitting the 4-year data to the FDA this year, as I showed in one of my slides. And so as soon as we submit the data and the FDA approves, if they approve, of course, there will be a barrier. The 3-year code, the code today will no longer cover Liletta.
I'm referring to your comments about the descriptor creating an access issue for a beneficiary. So did I misunderstand that?
I think what I was referring to is that when we switched over from J7, from the J7, sorry, I have to get all my J's correct, J7302 to J7297, many of the providers and the insurers haven't switched over yet. And so they're not billing and coding appropriately. Does that help answer your question? Okay, well, maybe I'm not understanding it.
I'm sorry, I'm not being clear. So when I hear you say the descriptor is creating an access issue, to me that means a beneficiary or a patient cannot get the device. Is that what you're saying?
I'm not saying that today the patient can't get the device. There are instances where they are using the wrong code. There are also instances in different states where they're requiring a prior authorization. Different beneficiaries have different requirements. So there does exist access barriers depending on which state you're in and which insurance company you use. Anything else?
Yes, I have a couple of comments to make. Thank you for your presentation. I'm always concerned when information comes out in a public hearing, especially now that we're live on YouTube and the whole world can watch us, that might alarm people, especially unnecessarily when comments made are misunderstood or aren't entirely accurate or aren't based on a full knowledge of coding and claims processing and et cetera. So if I may, I'd just like to make a couple of clarifying statements. First, there's always enough flexibility in the existing code set at any time for an insurer to assign a code to a product when they wish to, when it's something that they would include as part of their program benefit. It may sometimes involve signing of a miscellaneous code temporarily until such time as a new permanent code can be established, if it's going to be established. But there is always a way to identify something new, and that's very important to us because there's new devices coming out all the time, and they don't always come out the day before we publish final coding decisions. So we have to have a way to accommodate that so that there wouldn't be a barrier to access. Secondly, you mentioned that there would be a year and a half between new codes ostensibly for products based on an inconsistency between the FDA clearance cycle and CMS's coding cycle. And we've done a lot to make sure that we've got the narrowest window possible in terms of any lag time, which is why we change our policy to accept FDA clearances up to 3 months after the application deadline. So hopefully sometimes we can catch soon enough to have a 9-month window. In the meantime, there's always availability of miscellaneous codes, and CMS does have the flexibility to code sooner if there is a national program operating need. So again, we have flexibilities there, and it's not an automatic year-and-a-half wait for anybody to get a code, and certainly not to have access to a product. And in terms of describing the coding structure as an administrative burden, I wanted to say that in part, the reason for the time required to review applications is because we are wanting to make sure that there are FDA indications that would support the new code. And it sounds like in more than one instances, both brought to our attention today by a competitor and also by yourself, saying you're seeking coding for indications that simply do not exist now. And the FDA exists for everybody's protection. And I think it's a good thing that insurers are making sure that, and practitioners should make sure that patients get products only that for which there's an appropriate indication. And finally, the codes are not intended to capture indications for use, individual person eligibility for the product, or the insurer policy. If they did, codes would be pages long. That policy just has to remain in policy, and who gets what, and et cetera. For example, we don't have a code for aspirin, but if we did, we wouldn't have a code for aspirin for a headache, and a separate code for aspirin for a toothache. And so that would just be really cumbersome, and that in itself would be burdensome to try to administer. So that's all. Thank you.
Okay. At this time, we'll have a 20-minute coffee break. Please return at 10:31. All right, if everyone could start settling down, we're going to start in a minute. Thank you. Agenda item number 8, attachment 16.57, request to establish a new level 2 HCPCS code to identify Choline C11 injection. Primary speaker is Mr. Peter Webner.
Good morning. My name is Peter Webner. I'm an employee of Zevacor. I receive my salary from the company, so I have an interest in this product. Thank you, committee, for your preliminary recommendation. Thank you, everyone, for attending. C11 choline is a diagnostic radiopharmaceutical. Its indication is for use in men that have had prior treatment for prostate cancer. They have biochemical recurrence and negative morphologic imaging. So part of our challenge is this product has a very, very short half-life. It has a 20.4-minute half-life. Our label is a 1-hour expiry. The original product was approved for Mayo Clinic on September 12th of 2012. It was approved and limited to use at one facility at that time. Mayo waived market exclusivity rights with its NDA, and on November 13th, 2015, Zevacor received FDA approval of our ANDA for C11 choline injection. We have some limited distribution. We have about 17 centers around the U.S. where we can deliver within approximately a 30-minute radius from our production facilities. So our request was A9 XXX choline C11 injection, diagnostic per study dose up to 20 millicuries. The preliminary recommendation of the panel was choline C11 diagnostic per 1 millicurie or per millicurie. We disagree with the preliminary recommendation regarding the per millicurie units. We have concerns with 3 key areas. One is provider challenges to appropriate bill using a per 1 millicurie increment because we have a short 20.4-minute half-life. Our structure is based on the short half-life. Our product label is for a 10 to 20 millicurie injection per patient study. We have received a transitional pass-through approval, and we have a temporary C9461 code for choline C11 diagnostic per study dose. So again, our package insert is 10 to 20 millicuries, primarily because of the short half-life. So to give you an idea, once the product is produced, it takes us 10 minutes to package it, get it into a delivery vehicle. It travels about 30 minutes to the end user site. When it gets to the end user site, it's about 20 millicuries. So that's, 40 minutes into the 1-hour product expiry. Within that 20 minutes, it gets used. So within that 20 minutes, once it gets to the end user, that dose can be anywhere between 20 all the way down to 10 millicuries. So again, the vagaries of patient venous access, things like that, it makes it very difficult to measure the dose as it's given. Just some precedents, other radiopharmaceuticals that have a per dose descriptor. Virtually all these products have a much longer half-life. Other products that we manufacture and deliver within the radiopharmaceutical space, oftentimes other PET drugs for oncologic use, we can deliver half an hour to an hour prior to the injection time. But with a short half-life, it makes it virtually impossible for us to do so. So what we are requesting is a reconsideration for a per dose descriptor, just based on the past precedents with other radiopharmaceutical HCPCS codes. Inconsistency with the current effective pass-through code descriptor of C9461 for choline C11 diagnostic per study dose, and just the complications for providers to bill the choline given its brief 20.4 minute half-life and 1 hour expiry per the package insert. So it makes it very difficult to track it if it's a per millicurie versus a per dose. Thank you for your consideration. Appreciate it. Okay.
We will now hear from Denise Merlino.
Good morning. Denise Merlino, Society of Nuclear Medicine and Molecular Imaging. We would like to thank the panel for creating a code. We do appreciate a code for C11 choline. We, like the presenter, would request the per study dose description for several of the reasons that Mr. Webner already described. We did send you a letter in advance, and hopefully you have that, but if you don't have it, you should have it. One of the things that we thought would be helpful for the panel is we created a table that would show some of the complexities around the fact that this product does decay. We did show you 3 different examples, one where the patient arrives, or the dose arrives and it's scheduled to be 20 millicuries. The site receives it at 18 millicuries. The patient is apprehensive, so there's a little bit more time before we actually give it. And so there's a discarded, really decayed amount. And there might be a way to code that if we could interpret the J code, the JW modifier, in order to bill that. So that would be 12 millicuries of what the patient was administered and 8 millicuries with the JW modifier. So it just adds a level of complexity to what providers would have to do. They also would have to mark down why there was decay or why there was disintegration of that product. Example number 2 in your handout shows that we ordered 15 millicuries. We had no traffic issues, so we actually received 15 millicuries, but the patient came early, the scanner was ready ahead of time, and in this instance, we actually have 20 millicuries, and we're ready to go, and the tech wants to administer it, and it's well within the limits to give the 20 millicurie dose. But in that instance, Society of Nuclear Medicine is not even sure how to tell somebody what we would actually recommend for them to code and bill, because it was 20 millicuries administered, but you actually paid for 15 millicuries. So we think there's a disconnect in that type of scenario. We did have a conversation with Mayo Clinic and WashU, which also sent you letters, and the Society agrees with their recommendation that per study dose is a much less burdensome way to go for the sites, although they would have to create charge masters that had 10 different iterations of the product in order to get it to marry to the actual cost of the product. So we do think that it does add a level of complexity and administrative burden that we just do not think is necessary. We think the per study dose with putting 1 unit on it makes sense for this product. Thank you.
We will now hear from Terry Wilson.
Thank you. Hi, I'm Terry Wilson. I'm with the Medical Imaging and Technology Alliance, and we represent the PET radiopharmaceutical manufacturers. And we are pleased with the proposed decision of awarding a permanent A code for this product, but we agree and support the manufacturer's request and the Society of Nuclear Medicine's request for a code descriptor change to a per study dose. there have been reasons stated, obviously, but it is consistent with all of the current PET radiopharmaceutical code descriptors, our per study dose. And Peter and the Society of Nuclear Medicine have discussed in depth the challenges that would be placed on this particular product with a per unit. So we thank you for the preliminary decision, but we urge you to reconsider the code descriptor. Thank you.
Are there any questions or comments?
How do you price this product? It's based on the prescribed amount, or you calculate certain amount for the decay?
It's based on a 10 to 20 millicurie. We're assuming most users would request a 20 millicurie dose because of the very limited half-life. It's a 1 hour expiry. So the biggest challenge we have with this is any patient issues. Again, most of these patients have venous access issues and other things. Scanners go down. So we've priced it based on a unit dose going out the door. Also, based on the short half-life production yields, pretty much every batch is about a patient dose, typically.
So is it a flat rate, regardless of the dose prescribed?
Correct. And that's the way it's priced currently in Red Book. Any other questions? All right, thank you very much.
Okay, agenda item number 9, attachment 16.58, request to establish a new level 2 HCPCS code to identify NeuroSeq. Primary speaker, Dr. Susan DeSanti.
Thank you. My name is Susan DeSanti. I am a full-time employee of Piramal Imaging, and I am the head of medical affairs in the U.S. I'm also a member of the Medicare Evidence Development and Coverage Advisory Committee. On behalf of Piramal Imaging, I would like to express our support for the workgroup's preliminary decision to establish a Q code, Q9983, to identify Piramal Imaging's diagnostic radiopharmaceutical NeuroSeq, fluorobetadine F18, effective July 1st, 2016. While we agree with the workgroup's decision, we urge CMS to consider assigning a permanent A code to NeuroSeq instead of a temporary Q code. Assigning an A code to NeuroSeq would maintain the consistency of the HCPCS code set as a whole, as well as a coding of the other products in NeuroSeq's therapeutic class. Currently, there are 3 FDA-approved beta-amyloid imaging agents. One, from Eli Lilly, Amyvid, is described as a permanent A code, while both NeuroSeq and GE Healthcare's Visil will both be described by temporary Q codes starting July 1st, 2016. Different coding classifications for different radiopharmaceuticals within the same class may be confusing to providers. Therefore, while we support the preliminary recommendation to establish a Q code within this class to identify NeuroSeq, we urge you to consider assigning a permanent A code instead, with the same effective date of July 1st, 2016. Thank you.
We will now hear from Denise Merlino.
Denise Merlino, Society of Nuclear Medicine and Molecular Imaging. The Society supports the Q code. We have no preference over the A versus the Q code, but we do agree with the code description in its entirety. So thank you very much, and if you have any questions.
Terry Wilson.
Thank you. Terry Wilson with MIDA again. We appreciate the preliminary decision for the Q codes and the code descriptors. And while we believe that these codes may help address some of the coding challenges that would be experienced by participants in the IDEAS study, we do remain concerned about inconsistencies with coding and code descriptors for PET radiopharmaceuticals. So we support the manufacturer's request also to urge you to look at a permanent A code for this product and the one that is the next subject. So as we said before, currently all unique existing PET radiopharmaceuticals approved on the original NDAs have received permanent A codes. And these 3 products are utilized in a coverage with evidence development study, the IDEAS study. And so there is inconsistency with the 3 products. It's a tracer agnostic study, so all 3 of these products can be used in the study, but there are inconsistencies with one product having a permanent A code and 2 products having been awarded in July of temporary Q code. So that could create some confusion. So as we stated before, we would support the manufacturer's request to reevaluate and potentially look at the A codes. Thank you.
Are there any questions or comments regarding this item? Okay, thank you. Agenda item number 10, attachment 16.66, repeat request to establish a new level 2 HCPCS code to identify Visil. Primary speaker is Ms. Meredith Johnson.
Hello, my name is Meredith Johnson and I represent GE Healthcare. I am a full-time employee. We appreciate the opportunity to respond to a preliminary decision regarding our HCPCS Level 2 code modification request for the radiopharmaceutical Visil Flutemetamol F18 injection. Flutemetamol is a radiopharmaceutical approved by the FDA for PET imaging of the brain to detect beta amyloid neuritic plaque density in adult patients with cognitive impairment who are being evaluated for Alzheimer's disease or other causes of cognitive decline. We requested a permanent HCPCS code in the category A95, with a code descriptor Flutemetamol F18 diagnostic per study dose up to 5 millicuries. The reason for our request was twofold. First, there is no HCPCS code that accurately denotes this product that is used in PET imaging. And second, the established C code, C9459, can only be used in the hospital outpatient department. We very much appreciate the working group's preliminary decision to assign a unique HCPCS code for Flutemetamol, where the unique code Q9982 would replace the C code in the hospital outpatient department and the A9599 code that's currently used in the physician office and freestanding imaging facility setting of care. But we respectfully request that the preliminary decision is revised for a permanent A code rather than a temporary Q code. The preliminary decision to assign a temporary Q code creates an unfair competitive advantage for one radiopharmaceutical. Currently, there are 3 FDA-approved beta amyloid imaging agents on the market and at least 1 more in the research pipeline. One agent has been assigned a permanent code, as we've heard, in 2013. And since all products are uniformly covered under Medicare's coverage with evidence development, all agents should have parallel coding assignments to ensure providers understand equal treatment of the 3 agents with respect to coverage and reimbursement under CED. Perhaps the HCPCS work group assignment of a temporary Q code is in light of the fact that coverage of Flutemetamol is tied to CED, which is a temporary coverage status. However, this does not support the lack of parity in the coding assignments across the 3 FDA-approved beta amyloid imaging agents. We are concerned that the assignment of a permanent A code to one agent and a temporary Q code to the remaining agents may suggest to providers that reimbursement is more favorable for A9586 versus Q9982, which in fact is not the case. CMS has not provided any transparent rationale to explain why some beta amyloid imaging agents are assigned permanent A codes while others are assigned a temporary Q code, and confusion amongst providers and patients is likely. We also believe an assignment of a temporary code creates unnecessary operational hurdles for providers when a temporary Q code is transitioned to a permanent A code. There's a lag in updating charge masters with new codes, resulting in unnecessary denials and claim resubmissions. Finally, we believe that the assignment of a temporary code introduces the potential for errors in data analysis and claims tracking for reimbursement purposes. This is because information systems do not always store historic HCPCS codes in a way that ensures all claims for procedures are pulled for rate setting in situations where a code for a procedure or item has changed over time. Therefore, we urge CMS to establish a permanent A code effective immediately and no later than July 1st, 2016, as the IDEAS study, which is the Medicare sponsored coverage with evidence development study, is currently recruiting patients. Thank you.
We will now hear from Denise Merlino.
Denise Merlino, Society of Nuclear Medicine and Molecular Imaging. Same comment from the last agenda item. The Society of Nuclear Medicine appreciates the new code effective July 1st. We have no preference on the A code versus the Q code, although A codes are consistent with a lot of the other products, but from our perspective, the Q code will essentially work in the same light as the A code will, and what's most important for us is the description, so we appreciate the description. Thank you.
Ms. Terry Wilson.
Thank you. I've made my comments on the previous one, and I've submitted the comments to you on both, so thank you.
Are there any questions or comments?
Thank you for your presentation. And I don't know what the outcome, what the final coding decision will be, A code versus Q code, but I would like to assure you that an A code as opposed to a Q code creates no competitive advantage whatsoever. And it's just two different ways of reporting. Our reason for establishing a Q code was to implement a code prior to January 1 of 2017. And that's what temporary codes are used for. So just to let you know, we use that as a mechanism to get a code sooner than next year for you guys.
Okay. And I appreciate that clarification. I think our concern is, you know, as we're out talking to clinicians in the field, there are concerns of understanding why our product is described with C codes or a miscellaneous code and other products have A codes. We have received requests for why haven't we applied for an A code, which, you know, we have reassured them that we have applied for A codes and are working with CMS to do that. So we are very hopeful that in the near future we'll be able to have a permanent code.
Agenda item number 11, attachment 16.62, request to establish a new level 2 HCPCS code to identify Darzalex. There are no speakers for this item. Are there any questions or comments? Agenda item number 12, attachment 16.65, request to establish a new level 2 HCPCS code to identify Lipiodol. There is no primary speaker for this item. There are no 5-minute speakers. Are there any comments? Agenda item number 13, attachment number 16.59, request to establish new level 2 HCPCS code to identify Otiprio. Primary speaker, Dr. John Ansley.
Good morning. I'd like to thank the panel for their consideration and thank the audience in attendance. My name is Dr. John Ansley. I'm a practicing otolaryngologist. I'm also additionally fellowship trained in pediatric otolaryngology. I've been practicing for 16 years and been involved in multiple research studies. Recently, I've been working with Autonomy, who sponsors Otiprio, and I've been delighted that they've invited me to talk about Otiprio. I'm also delighted that they're compensating me for my time in travel. So why are we here? I'd like to give a scientific background on this new thermosensitive otic drug. This is the first and only approved FDA single-dose ciprofloxacin otic suspension. This is approved for children undergoing tympanostomy tube placement for injection at the time of surgery. It's approved for children who have bilateral chronic serous otitis media. This is a drug that's administered by the physician, and I'd like to spend some time discussing the need and patient benefit. We are recommending that a HCPCS code be established, and I'd like to go in great detail about our rationale for why we think this code is needed. Again, this is the first and only drug approved by the FDA for pediatric patients with bilateral otitis media with effusion undergoing tympanostomy tube placement. This medicine is given intratympanically through an injection at the time of surgery by the physician. Each vial of the medicine contains 1 milliliter, but the standard dose for patients would include 0.1 milliliter in each ear. The unique properties of this drug is its thermosensitivity properties. It is a drug that is liquid when injected, but at body temperature it becomes a gel. This gel will allow that the patient will get a full course of antibiotics with 1 single dose. It will minimize systemic delivery of the drug and systemic exposure to the drug. I've been using this drug in multiple clinical trials and have experienced this and used this in over 100 patients and found it to be very effective. So for most of you, and I imagine some of you have had kids who've had surgery, I'd like to talk about what the disease process this treats. This is otitis media with effusion. This is a condition where a child gets middle ear fluid. It's often without symptoms of an acute infection. Because the fluid sits in the middle ear, it can lead to long-term problems related to hearing loss. Most kids who get this problem will indeed have difficulty hearing, which can in fact lead to trouble with speech and language development and learning problems in school. Most kids who develop this do develop bilateral disease, and this image essentially shows the external ear canal and the fluid sitting into the middle ear. This is often called a glue ear or serous otitis media. Let me back up. The treatment for this condition is surgery for most patients. If the fluid sits in the middle ear for over 3 months, or if the child gets persistent middle ear fluid and recurrent infections, it's generally recommended that they undergo surgery. And there are stringent criteria by our academy and for their recommendations on which kids would be good candidates for surgery. The surgery involves making a small incision in the eardrum, then suctioning out all of this middle ear fluid, and then placing the tube into the middle ear space. At no point during the surgery are we injecting any medicine into the middle ear. Why this drug is important is that the main complication of this surgery is otorrhea. Otorrhea is defined as draining of fluid from the middle ear space following the surgery. So you can imagine that that fluid that's been sitting there is often infected and it will drain continuously. Some patients will have drainage immediately after surgery, or some patients will have delayed drainage. It's actually a very troublesome problem, especially for the parents. They brought their child to have the surgery. Surgery went well, but unfortunately the child continues to battle an ear infection. Otiprio addresses this problem by becoming a method of treatment for this problem. Right now, the standard of care is the use of otic antibiotics. There are no approved antibiotics for this condition. Most people or most physicians will use the otic antibiotics as a standard of care, though it's not FDA approved. There are lots of problems with the use of antibiotic eardrops. One, we're not sure about the penetration, or actually if it's getting to the site of the middle ear, because it has to go and traverse through a small tube. Additionally, patients or children don't seem to like it. They sometimes complain that it burns. Most kids need the dosing twice a day for 7 days, which can be a chore with daycare. It's often a battle to hold the child still. The child will often get up immediately and move, and so again, we're not sure of what the penetration of the ear is. And what studies have shown is that, in fact, there's actually a very low compliance rate with the use of antibiotic eardrops following surgery. Otiprio is intratympanically administered by the physician at the time of surgery, so there's assured compliance. The drug has been studied extensively, and I'll talk a little bit about 2 of the studies that have been performed. Again, this is a polymer that's a thermosensitive polymer. When the drug is initially drawn up, it is liquid. The drug is drawn up into a catheter and then injected into the middle ear. After the injection into the middle ear, a tympanostomy tube that we see here is placed. I want to emphasize here that this is something that's atypically done with tympanostomy tube surgery. In fact, given that this is the only FDA-approved drug, it's not something that actually is ever done. There's additional skill and time involved in actually performing this injection here that goes beyond the typical tympanostomy tube placement. Tympanostomy tube placements are done over 1 million times a year. This wouldn't necessarily be used in every patient, but there's a large scope of patients who would benefit from this drug. As I mentioned earlier, this drug has been studied. These are 2 multi-center randomized controlled blinded studies, and what they looked at was to see treatment failures at day 15 for patients who were given Otiprio plus tympanostomy tube placement and patients who received surgery only in a sham injection. And what was seen was that the treatment failure rate was decreased significantly for patients who got Otiprio. Treatment failures were described as patients who had otorrhea, or patients who were required otic or systemic antibiotics, as well as patients who were lost to follow-up or missed appointment. And what you can see is that the sham group had a failure rate of approximately 45% or 45%, whereas in the 2 studies, that treatment failure rate fell to 25% in one study and 21% in the other study, and both of those data points are statistically significant. So Otiprio has been approved as of December 10, 2015 for patients who are undergoing bilateral tympanostomy tube placement who have bilateral otitis media. That surgery is done in ambulatory surgery centers, hospital outpatient departments, as well as the physician's offices. Fortunately, there are some future indications for this drug, which include the initiation of a phase 3 trial for swimmer's ear. The typical name is otitis externa, but most of us know it as a swimmer's ear, as well as patients who have actually had the tympanostomy tubes and then the ear starts to drain. A study is ongoing right now where Otiprio will be used to treat those patients. At the present time, those patients will require antibiotic eardrops, but once again, we're trying to find a new and novel treatment for the treatment of patients with otitis media with tubes. All of these injections will not involve surgery, but will instead involve treatment in the physician's office. So there's the recommendation that a new J-code be established. I am not a coder. I don't involve myself a whole lot with codes. I leave that to my office staff to handle that. But I'm told that without a J-code, it will be impossible for us to bill for this product or to purchase a product and then give it to our patients. And without a J-code, we can expect to have access barriers to providing this new therapy for our patients. Again, the J-code is the best method for providing access to this medication. Not all patients who undergo tube would receive Otiprio, and patients who get the drug, the cost of the drug is not reflected in the payment for the drug. There's no historical data or charge for this because it's a new drug, and there's really no drugs that are actually given intratympanically during surgery. In the physician's office, the physician would need to purchase the Otiprio to provide it to the patient, and there needs to be a way for physicians to get reimbursed for the purchasing of this drug, and a J code would allow for that to be done. So we respectfully disagree with CMS preliminary decision to deny the establishment of a new code based on the fact that Otiprio, or this drug, is part of the procedure. In fact, we respectfully disagree because the procedure payments do not reflect the cost of the Otiprio either in the hospital, outpatient department, ambulatory care centers, or in the physician's office. Intratympanic drugs have never been a part of tympanostomy tube surgery, and I've done, or I average at least 200 surgeries a year, and until Otiprio, I've never done intratympanic injections of any type of therapeutic or diagnostic agent while doing tympanostomy tube placement. Otiprio will also be at the discretion of the physician, such that not all patients who have tympanostomy tube placement will be receiving Otiprio. In summary, Otiprio is the first and only drug approved by the FDA for pediatric patients undergoing a tympanostomy tube placement with bilateral effusion. Otiprio has been shown to significantly lower the rates of treatment failures in patients who getting tubes versus patients who get tubes alone. This drug is administered at the time of surgery by the physician. The main advantage to that is that compared to antibiotic eardrops, which again are not FDA approved and are currently the standard of care, this provides assured compliance. It provides full dosing with one injection, and actually will be much superior to drops in that regard. Otiprio costs at the current time are not incorporated into any of the procedure codes associated with tympanostomy tube placement. A specific J code is needed to facilitate claims processing and a way to get payments to the providers. Thank you for your time and consideration.
We will now hear from Gail Dalbert.
Hi, thanks. My name is Gail Dalbert, and I'm here today on behalf of Autonomy. And I, too, respectfully disagree with CMS's preliminary determination to deny a new code for Otiprio injection. The HCPCS work group's rationale for denying a code is that the product is an integral part of the procedure, and payment for that service includes payment for Otiprio. I take issue with that. And I actually looked up the word integral, and it means essential for completeness, relating to or belonging to a part as a whole. And as you heard Dr. Ainsley indicate, up until Otiprio was introduced a few months ago, there were no intratympanic injections, and there were no FDA-approved drugs like Otiprio being used for these patients. I actually then drilled down, looked in the practice expense database on CMS's website. There are no injectable drugs included within the direct practice expenses for tympanostomy procedures. Similarly, there's no needles or syringes or anything that would suggest that a drug had been injected during tympanostomy procedures. As Dr. Ainsley also mentioned, Otiprio would be used in some patients, but not all patients, primarily pediatric patients who have had problems in the past. We also looked at the Medicare physician fee schedule payment rates for the procedures and compared that to the cost of Otiprio, and again, there's a big disparity there. With respect to drugs being used or being considered integral to a procedure, We also would like to point out that many drugs are integral to the procedure. For example, photodynamic therapy for age-related macular degeneration requires that a drug be administered in order for that procedure to be carried out. Yet that drug has a J code and is paid separately. Likewise, and just picking up on the conversation here today, a radiopharmaceutical is imperative for every single nuclear medicine procedure, and yet those products are paid separately, in part because it's the best way to make sure that you're paying accurately and appropriately when that particular drug is used. So I would respectfully request that you reconsider your initial determination and reconsider and grant a J code to Otiprio so that claims can be processed efficiently. Payers will only pay for the product when it's administered to certain patients, those patients that would most benefit from the drug. The fact that it is a new drug, it's a therapeutic drug, not a diagnostic drug, and there's ample precedent that exists that drugs used as part of procedures are still granted HCPCS codes so that the billing can accurately reflect the products and services provided to that particular patient. So, any questions?
Hi, Gail, just a comment. We did establish a C code for this drug effective July 1 for use in the hospital outpatient facility and ASC facility. I do have a question. If a J code were to be established for this drug for use in the physician setting, what dosage descriptor would be preferred?
Well, since I haven't had the pleasure of seeing how the C code descriptor is drafted, I would hope that it would be per single dose vial. The properties of the drug are very unique. As you know, it's a liquid at room temperature, and then it forms a gel. So as you're beginning to withdraw the drug and injecting it, there's a certain amount of space that occurs. And they actually did a, let's see if I remember the exact term, a user feasibility study on whether or not you could actually withdraw more than the required dose, and you can't physically get it out of the vial because of the unique properties. And the FDA approved it as a single patient use vial. So
how many milligrams of Otiprio is in a single vial?
I think it's referred to as 60 milligrams, but it's delivered as 0.1 ml to each ear.
Sorry, 16 milligrams or 6 milligrams?
It's 60 milligrams
60, okay,
in one vial, but the standard dose is 0.1 milliliters, so each patient would be given 6 milligrams in each ear.
Okay, so for the C code, the long descriptor reads installation, ciprofloxacin, otic suspension, 6 milligrams. So that C code is posted on the HCPCS website, and it's effective July 1.
Okay.
Any other questions or comments for me?
And Marjorie, is there any opportunity to add to that long descriptor, or what's the short descriptor? Is it per single-use vial? Right. Right. What, did I say single use? Yeah, sorry. Single patient use. Okay. Well, thank you.
Thank you.
I think there's one other comment here.
Hi, my name is Iris Tam, and I'm the Vice President of Patient Access and Quality in the Medical Affairs Organization at Autonomy, and I'm a full-time employee. I would just like to address the panel and request that the descriptor include 1 ml vial, single-use vial for 1 ml. Thank you.
Agenda item number 14, attachment 16.68, request to establish a new level 2 HCPCS code to identify Omidria. There are no speakers for this item. Are there any questions or comments? Agenda item number 15, attachment number 16.29, request to establish a new level 2 HCPCS code to identify Inflectra. Primary speaker is Mr. Chris Colburn.
Good morning. My name is Chris Colburn, and I'm a full-time salaried employee as the Director of Federal Accounts, U.S. Market Access for Biologics at Hospira, a Pfizer company. Building on Pfizer's expertise in biologics and our regulatory, commercial, and manufacturing strengths, Pfizer is working to advance high-quality, effective biosimilars with an acceptable safety profile that provides patients and prescribers with additional treatment options. With 30 years of experience manufacturing recombinant DNA products and significant expertise in the clinical development of novel products in many therapeutic areas, Pfizer is well positioned to meet the demand for manufacturing high-quality biosimilars. On behalf of Pfizer, we would like to thank the CMS HCPCS group for the decision to grant a unique code, Q5102, for the injection of infliximab biosimilar in the accompanying modifier ZB to identify Pfizer Hospira as the manufacturer of the first FDA-approved infliximab biosimilar, Inflectra, effective July 1, 2016. We respectfully request that CMS assign a permanent J-code for Inflectra and discontinue Q5102, effective January 1st, 2017. As the second product in the U.S. to be approved under the biosimilar approval pathway, a permanent HCPCS code will ease administrative burden and enable consistent provider billing when administered to Medicare beneficiaries and patients covered by other payers. Given that not all payers may accept the Q code, this may create an additional burden on providers who would need to track which payers accept the unclassified code and which accept the Q code, along with their respective documentation and required coverage requirements. If the Q code assigned to Inflectra is not accepted by all payers, it may create difficulties for providers and in turn may limit uptake of a clinically and cost-effective product for beneficiaries and patients with inflammatory conditions. In conclusion, the FDA approval on April 5th, 2016 demonstrates the importance and need for this product in the market, and it's critical for providers to specifically identify the product administered to the patient to improve continuity of care with the same treatment. Inflectra should be assigned a permanent J-code to ensure consistency among payers, be distinguished from other therapies reported by unclassified codes, and limit provider burden. Thank you for your time and your consideration.
Are there any questions or concerns?
I don't know you can answer this question, but do you have any estimated product launch date?
We don't have one yet. This is a product that still has some legal hurdles that it's clearing with the reference product.
Any estimate?
Not right now. We're hoping soon. Any other questions? All right. Thank you very much.
We have concluded our agenda for today. We would like to thank everyone for their attendance at today's meeting and for all of your excellent and thought-provoking discussion and for taking time out of your busy schedules to come and appear in person and to share with us all of your valuable input. We'd like to say have a wonderful day, and we'll see you tomorrow or we'll see you next year.